Splenectomy overview. Splenectomy is a surgical procedure involving the removal of the spleen. The spleen, located in the upper left abdomen, plays an essential role in immune function by filtering blood, removing old or damaged red blood cells, and producing white blood cells and antibodies to fight infections. Splenectomy may be performed for therapeutic or diagnostic reasons. Indications for splenectomy. Splenectomy is indicated in various medical conditions, which can be broadly categorized into hematological, traumatic, and other systemic diseases. 1. Hematological disorders. Hereditary conditions. Hereditary spherocytosis, hereditary elliptocytosis, pyruvate kinase deficiency, thalassemia major, acquired conditions. Immune thrombocytopenic purpura, ITP, refractory to medical treatment. Autoimmune hemolytic anemia, HA. Myeloproliferative disorders, e.g. primary myelofibrosis. Splenic sequestration crisis in sickle cell anemia. Hypersplenism causing pancytopenia. 2. Trauma, splenic rupture due to blunt or penetrating trauma with hemodynamic instability. Ca3. Malignancies, splenic lymphoma or leukemia, hairy cell leukemia, splenic metastases. Ha4. Infectious and inflammatory conditions, splenic abscess or unresolving infection, splenic hydatid cyst, chronic splenic vein thrombosis causing significant portal hypertension. 5. Diagnostic reasons. To confirm a diagnosis in certain hematological malignancies when other methods are inconclusive. Complications of splenectomy. 1. Immediate complications. Bleeding, intraoperative or postoperative hemorrhage, injury to adjacent structures, damage to the pancreas, stomach, or diaphragm. Infection, wound infection or abscess formation. Thrombosis, portal or splenic vein thrombosis. 2. Long-term complications. Overwhelming post-splenectomy infection, a life-threatening condition caused by encapsulated organisms such as Streptococcus pneumoniae, Neisseria meningititis, and Haemophilus influenzae type B. Thromboembolic events. Increased risk of venous thromboembolism, e.g. deep vein thrombosis, pulmonary embolism. Hematological changes, persistent thrombocytosis, Howell-Jolly bodies and target cells on peripheral blood smear due to loss of splenic function. Immunodeficiency, reduced ability to clear encapsulated bacteria. Immunization schedule for splenectomy patients. Vaccination is critical for preventing infections in asplenic individuals. Ideally, immunizations should be administered at least 2 weeks before elective splenectomy or as soon as possible after emergency splenectomy. Recommended vaccines. 1. Pneumococcal vaccines. Prevnar 13, PCV 13, given first. Pneumovax 23, PPSV 23, administered at least 8 weeks after PCV 13. Revaccination with PPSV 23 is recommended every 5 years. 2. Meningococcal vaccines, MenACWY, Menactra or Menveo, quadrivalent meningococcal conjugate vaccine. MenB, Bexsero or Trumenba, meningococcal serogroup B vaccine, optional depending on risk. Booster doses every 5 years. 3. Haemophilus influenzae type B, HIB vaccine, a single dose if not previously vaccinated. 4. Influenza vaccine, annual vaccination against seasonal influenza. 5. COVID-19 vaccine, complete the primary series and stay updated with booster doses. 6. Others if indicated, hepatitis B vaccine, varicella vaccine if not immune. Key considerations post-splenectomy. 1. Antibiotic prophylaxis. Lifelong antibiotic prophylaxis, e.g. penicillin V or amoxicillin, is recommended, especially in children, to reduce the risk of opici. Adults may require antibiotics during high-risk periods, e.g. severe infections, travel. 2. Infection prevention. Early treatment of febrile illnesses and prompt medical attention for infections. Avoiding high-risk areas for malaria or ensuring appropriate prophylaxis when traveling. 3. Regular follow-ups. Monitoring for thrombocytosis and long-term vaccination compliance. By adhering to these guidelines, the risks associated with splenectomy can be effectively managed.